Okay, we're going to continue on with the second part to the Certified Medical Coding Specialist test prep, which is the ICD-10-CM. It's going to be the introduction to ICD-10-CM as well as the guidelines specific for chapters 1 through 7. So with our introductions, ICD-10, you're going to need to know what ICD-10 stands for. CM, which is the International Classification of Diseases. 10th revision, clinical modification, and the clinical modification is U.S. specific. Most countries, other than Australia, use the ICD-10 and it's not clinically modified. If you were to look up World Health and ICD-10, you're going to see a very different format from what we utilize in the United States. So the importance of it, why is it important? It's used to identify and classify patients' morbidity, mortality, diseases, injury, or conditions, and for basic health statistics. A diagnosis is added to every claim to let the insurance company know why the patient had the encounter with a provider or service. These codes are updated October 1st of every year. And there are actually 3 volumes for ICD-10. We only utilize 2 in the outpatient. Volume 1 is our tabular. Volume 2 is our alphabetic indexes to disease. And Volume 3 is ICD-10 PCS, the procedural coding system. It used to be located in I-9. We had inpatient procedures. Just like the inpatient procedures in I-9, they were very limited on what we could and could not code. So I-10 PCS book is a very detailed, and it's broken down into chapter specifics, just like we use for the ICD-10 diagnosis, but except it is for procedures. It is set up differently than the CPT, and it is for inpatient procedures. So it is a hospital base. So when you look in your study guide, volumes 1 and 2, they say our physician, and volume 3 is hospital. Hospitals use volumes 1 and 2 as well, but we do focus mainly for the physician side on volumes 1 and 2. Correct coding maximizes, so again, the importance is we want to have correct coding to maximize efficient physician's reimbursement and correctly report to the insurance company the reason for the encounter. They want to know why they're here. That's medical necessity. It's going to support it. It's going to support those procedures and those services, supplies that the patient receives during the visit. Correct coding also indicates conditions, diseases, and other problems that coexist at the time of the visit and will affect the treatment of the patient and possibly future treatment of conditions of the patient. So we want to make sure that we capture all of that information, because we may not do any testing today for a specific diagnosis. But if for example, if the patient notices that they were diagnosed with bronchitis during an emergency department visit, and a month later they're still continuing to have difficulty breathing, it's not subsiding, it's not improving, they may need to go in to do further treatment to determine what it actually is. Is it COPD? Is it chronic obstructive pulmonary disease, or is it something even more severe such as lung cancer? So we want to make sure that we capture all of those diagnoses, those signs and symptoms that are specific to the patient's reason for visit today. We want to make sure that we get to the highest specificity. because that improves the correct code. So the laterality, the specificity. We want to make sure that the documentation in the chart is being captured by the code selection. If we are only selecting codes that are unspecified, then that's going to actually cause issues for denials later. Other things we're going to look at is the content, the format, conventions, and guidelines. So first we have our content. We have the official updates of addition, revisions, and deletions. So depending on the publisher, depends on what's included and what's not included as far as content goes. How to use the ICD-10 CM. So if at any point that you kind of go blank, you don't remember exactly how you look something up, make sure that you have that marked in your ICD-10. The conventions, additions, deletions. So what's new this year? What have they deleted? If, for example, you are having to pay for your own resources each year, you're going to want to look at the additions and the deletions that are available through CMS, that are available through your publisher, to determine how many updates have been done. One year you may only have a few updates, so you can actually go through and make those changes in your book yourself, whereas another year you may have hundreds of additions and deletions, and you're going to have to invest in those resources. You've got your official coding guidelines. So they are located at the beginning of the book. Our publisher that we selected also puts the guidelines at the front of each chapter. So again, I like using the guidelines at the beginning of the book because I can find all my guidelines together, where some like to look at the guidelines in a specific part of it, but they also have examples. So both of those are very good to use. Illustrations, we need those illustrations to determine the location of things, how the disease process may impact those different organs. Our alphabetic index, our neoplasm table, table of drugs and chemicals, external cause index, tabular list of diseases and injuries, and our appendices. And depending on which publisher have, that's going to depend on how many appendices you have. The format within the book, we have codes that are actual codes that we report from 3 to 7 characters. You do have an appendix within your I-10 that has 3 character codes that are acceptable. So if at any point you're wondering, is this an acceptable 3 character code, you can go to the appendix versus looking in the tabular, but you can always look it up in the tabular as well. So we have 21 chapters, A to Z, except for U. They do not use U. Categories are 3-digit categories, so we have those categories within each one of our chapters. So the E10 is a category of type 1 diabetes. I10 is a category plus a code for hypertension. Subcategories, they continue to break down. That's the 4th digit specificity. So E10.1 is a subcategory of type 1 diabetes with ketoacidosis, and subclassification is the 5th digit, so it gets more specific. So then it breaks down the E10, either 10 or 11, with or without a coma for a diabetic one with ketoacidosis. Basic concepts. So we're looking at the outpatient. And again, I took this information from your study guide. This is what they focused on. This is what you need to focus on because this is what they're going to be asking questions. If you change to a different organization and their certification, you want to make sure that you look at their study guides for their certification, because they're gonna point out different tips and information that is important. And when they point it out, there's a high probability that it's going to be on the test. So you want to make sure that you look at any study guide that's specific to that organization, not publishers that have created study guides for them, but the actual study guide from the organization that gives the test. The reason for that is other publishers create overviews of the study guides for test taking. They're not actual specific to the organization test. So you cannot use concept-wise, you cannot use possible, probable, suspected, or rule out. Those do not indicate a definitive. In that particular case, you're going to use signs and symptoms. This is different, however, for the inpatient side. Inpatient, because they are doing tests, they're doing services, diagnostic tests and treatments that they're trying to rule out a possible diagnosis. We would pick those up because we're utilizing those services. So those rule out, those possible, probable, suspected are going to be picked up. Ruled out meaning that that is not a possibility. So it's rule with a D, ruled out. We would not use that. If it's not documented, you can't charge for it. The golden rule, if it's not documented, it wasn't done. So if it's not there, you can't assume something should be billed or coded. That documentation is a medical legal document. So we utilize that to support what we code. So example, the doctor submits a diagnosis of warts. However, the medical record does not indicate warts were evaluated during the encounter. Okay, this is kind of contradictory to one of our guidelines as far as if the doctor documents it on the discharge summary, it's documented. That may be the only place it's documented, but it's documented. We can pick that up. What this particular example is stating is that he just billed for the code and nowhere in the documentation does it state that. So depending on where you go in the real world, one of the things that you could possibly find is that on the discharge summary, what it used to be is we could pick it up. And then it went through a time where if we couldn't find supporting documentation of the diagnosis that was on the discharge summary, we had to get clarification. However, the new guidelines say that if it's stated on there, we can pick it up. So again, we can pick it up. Just make sure the policies and procedures in the real world where you go to work, do they accept that or do they want further clarification? Again, for this test, if it's documented, we can code it. If it's not, then you can't. Cross-reference codes, that means that you're going to go to the alphabetic index, you're going to look up the code, you're going to verify it in the tabular, you're going to read the notes, and you're going to make sure that you follow all of that information. Okay, then always check your coding conventions. We want to make sure, do we need additional codes? Is there sequencing information? Can we code it with this diagnosis? So coding conventions are very important. Always code to the level, the highest level of specificity. So again, that's one of the areas that does trip many coders up, and it has tripped up all of you at one point or another on making sure that you got all the way to the 7th character. So we want to go to the highest specificity. Okay, conventions. We've got our abbreviations, we've got our punctuation, our notes that we have. So first of all, abbreviation, we have NEC, which is not elsewhere classified. It also means other. And NOS is not otherwise specified, meaning it's unspecified. So an example that you could have is we have a headache that's allergic, not elsewhere classified. That's going to have G4989. We can see 8s at the end of a lot of codes. If it's unspecified, we normally see them in a 9. So it might be 99 or it just might be 9 as far as the last character. And so a not otherwise specified might be vomiting, and that would be E1110. So unspecified type of vomiting. Our punctuation, we've got guideline specific information as far as punctuation. They could be true false questions. So you want to make sure when they ask you a question about punctuation, you go to that area in your conventions and you read that. It's very specific on that. The brackets enclose synonyms. Slanted brackets in the alphabetic index, they include your manifestations. So that gives you your sequencing. So we'd have our diabetes code, and then if we had retinopathy, the retinopathy code would be in slanted brackets to indicate that would be sequence secondary. But our notes would also indicate that in the tabular. Parentheses, those are our supplementary words. They're also called non-essential modifiers. So those are nice to have, but we don't have to have them. And we're going to see those parentheses in our alphabetic index. Notes. The important notes that we have is the excludes 1, the excludes 2, code first, code also, and use additional. The excludes 1 means it's not coded here. So it should never be coded. The code listed with excludes 1 should never be coded in the category or the code that you're looking at. So an example, I-86 excludes 1 under I-86 is varicose veins of unspecified site is I-83.9, and it's an incomplete code, but it's telling us that we should code the 186 because we do not need to pick up the additional varicose vein code. Excludes 2 means it's not included here, meaning that if it is documented, it's not part of the condition represented. And the patient could have both of these, so we would code them at the same time if they're documented. Excludes 1, you should have highlighted pink. Excludes 2, you should have highlighted orange. Okay, code first. Code first is and code also are sequencing. Code first tells us that one would be coded before the one you're looking at. Code also tells us that the code that you're looking at previously, you're going to code in addition, secondary, code also. So these notes are normally indicated in red, and you highlight them in yellow. Use additional code, that's just telling us we need additional information. The code that we're looking at isn't complete in its documentation. A lot of times this comes with when we have an organism, or we're trying to get more specific on additional specifics of a coronary disease, such as we have I-2581 for our atherosclerosis, but then we may need to tell that it was due to a lesion or due to lipid-rich plaque. So we would want to add those additional codes to further specify the information. Our conventions going on, we have etiology and manifestation. We have and, with, in, see also, acute and chronic, signs and symptoms, combination, and laterality. So with our manifestations, they're found not only in the alphabetic index, but we can also determine that they're manifestations by what we see in the tabular. In the alphabetic index, that's where you're going to have your slanted brackets. For example, Parkinson's with dementia. So you would pick up the dementia is the G31.83 and the Parkinson's is the F02.80. So it's telling you the one in the brackets is going to be the manifestation. So that's how we would do that. In the tabular, it says in conditions classified elsewhere. So when we see that, that should be, if we have the underlying etiology for that manifestation, we should assign that one first. We don't always have it, but if we do, we need to assign it. And is interpreted as and or. So it can tell us with the and or, if it's documented, we can have both of the conditions that are documented or one or the other. With or in is interpreted also as associated with or due to. So these are, we're assuming a cause and effect relationship. These are the ones we're going to see with hypertension and chronic kidney disease, hypertension and heart failure, diabetes and retinopathy. So diabetes and chronic kidney disease. So we have those. If it's not documented as with, the default is without. So if we don't see with there, we don't assume a relationship. And at the same time, if the doctor says it's not due to that condition, such as we have heart failure and we have hypertension, but he says it's not due to the hypertension or it's not hypertensive, then we would code simply hypertension and heart failure. C and C also. The study guide here, it's not a very good note as far as what it referenced. It just simply says that you should reference additional terms. However, our conventions, what it specifically states in the ICD-10 book is C requires, it's mandatory that the coder looks at the condition that it says C that condition. If it says C also, it's a suggestion. So when you're in the index and you're looking and you have all the information that you need to properly go back and verify it in the tabular, you can stop there. However, if it doesn't give you quite enough information, it's telling you, it's suggesting you may want to go and look at these other conditions because you could possibly find a better, more suitable code. So C also is a suggestion if needed. C means you need to go and see it. That could be a true-false question as well. Signs and symptoms. So our signs and symptoms, we only want to code signs and symptoms when we do not have a definitive diagnosis. So the patient is having fever, they're having cough, they're having congestion, but nowhere does it tell us why they're having this. In the emergency department, the outpatient, a lot of times the doctor isn't going to know for sure until a few days later after he gets test results back. So in that particular position, we're going to assign signs and symptoms. So for example, the child has an ear pain, and at the end of the visit, they're diagnosed with otitis media. So you would report otitis media and not the ear pain because we have a definitive cause. Another, with our signs and symptoms, we also want to make sure that if we have signs and symptoms that's not integral to that disease process, for example, they have fever, they have cough, and they have congestion. The cough and congestion is associated with acute bronchitis, but the fever was not. we would assign the acute bronchitis plus fever. Acute and chronic conditions. With acute and chronic conditions, for the conditions that are listed in the alphabetic index, and you have the indented terms for acute and chronic at the same indentation level, you're going to assign, and there's not a combination code, you're going to assign an acute and a chronic code for that condition, with the acute being sequenced first. The reason you want to assign the acute is because the acute exacerbation is what brought the patient here today. A patient can have a chronic condition and not have a reason to present to the doctor's office or the emergency department for treatment. An acute exacerbation is what prompted them to come to the visit today. So we want to sequence those first. Combination codes. Combination codes are where you have one code that is for multiple conditions. So it's a etiology and a manifestation, or a manifestation and a complication that goes together. So for example, we could have edema, which is swelling that's due to salt retention. So instead of coding edema and salt retention, you're going to code E870. That is the one combination code. However, we're going to have certain codes, certain conditions that require multiple codes to completely describe the patient's condition. Laterality. So some codes are specific with laterality. We have right, we have left, or we have bilateral. We can have unspecified, meaning we don't know. And that is in a certain, I do see that. We don't know for sure which side something is impacting. We don't like to see that a lot, and sometimes those will specifically get denied by insurance carriers. But we want to make sure if we have it or know it, we can assign it appropriately. So 1, 2, 3, 1 is right, 2 is left, 3 is bilateral in a lot of cases. However, you get into the ears and you get into some of the fractures, that may not necessarily be the case. Okay, next. All right, convention, our keys. So this is one of the things with making sure we get to the highest specificity, making sure we go up to the right number of characters per code. The 4th, 5th, 6th, and 7th. You'll notice that it's got a check mark, and the 4th, 5th, 6th, and 7th, the first ones are in red. They're kind of a burgundy color in your book. This is telling you that when you get under that category, that you need to continue under that category until you get to the highest specificity. The blue is telling us, it's got a check mark and an X. It's telling that there's a placeholder. In that particular case, you're going to go and use the note box at the beginning of the category to ensure that you get the right extension code at the end. So that's telling us that we may have to use X's because that code doesn't go up to 6 characters. So the example here is T33.90, which is the code. And at that point, it's telling us we need that 7th character. So we also need to put a placeholder in the 6th place to hold it. If you don't have that, it's an incomplete code, and that does cause denials. Now, are the extensions that are most common for the encounters are initial, subsequent, and sequela. However, in fractures, and when we get to that, you're going to see that there's more letters involved here. But overall, we normally use A, D, and S for most of them. A is for active treatment. It's our initial visit for the purpose of deciding what treatment is required. So this is until the healing happens. So the visit results in a changed active care plan. It could be a follow-up visit for fracture not healing and decision for surgical repair. The patient may need additional treatment and refers patient to see another provider for consult. So both the treating and the consult would be initial. I would look at these examples in your book because they actually could be test questions that are coming straight from your study guide. Another example of initial would be prescribing meds. Referral to a physical therapy is considered active because the injury is not completely healed. Subsequent is the first time a provider is going to see a patient for a fracture to continue post-treatment. So they're just checking to make sure that it's healed at this point and there's no further treatment that's needed. It would be considered subsequent. So the patient had a fracture or surgical repair when they were on vacation. And so this is the first time since they returned from vacation, and they're just recommending x-rays to make sure that there's no complications and everything's healing appropriately. Okay, sequela is the late effect or residual after an acute phase of the illness or injury has occurred. So it's normally, for example, a patient had an automobile accident 6 months ago and they're coming in now because they have hip pain, or the patient has dysphagia, but a month to 6 months ago they had a stroke. So it was due to the stroke. So if they say dysphagia due to a stroke and the stroke was 6 months ago by the documentation on the chart, it's going to be a sequela. All right, so now we're going to get into the specifics for each chapter and what this coding certification is looking at. It's not going over everything because, again, they focus mainly on CPT. So the ones that they really point out, those are the ones you need to pay attention to. Tips here. The first tip is you need to, the coding guidelines give you many answers for correct coding, and these guidelines will identify I-10 codes for chapter specific questions, sequencing, and coding conventions. That actually could be, just out of the tip, could be a question on your test. So, for example, chapter-specific instructions to determine and verify correct coding. The exam focuses on certain guidelines for each chapter. You want to get in the habit of cross-referencing codes in the tabular area of ICD-10, and that section and those sections give additional information such as add-on codes, what is coded in addition to the main code, codes included or excluded from the main term, and other information not found in the tabular section. And then finally, sequencing is key to the correct coding. You want to make sure that you pay close attention to the guidelines for correct sequencing of codes. The chapters that we're going over is 1 through 7. So we're just going to jump right in to chapter 1. So chapter 1 has to deal with infection and other parasitic diseases, and it's A00 through B99. What they focus on for the test here is mainly HIV. They're gonna ask you questions, especially sequencing questions with HIV, and you will, with the I-10 codes, you normally have 5 answers that you have. The 5 answers, they put them in a certain order, and it will tell you 2 of the answers will be it's A and B in that order, or number 2 would be B and C in that order, or you would pick A or B. So again, pay attention to sequencing information. So the first is if the patient presents with a condition related to HIV, the HIV is going to be sequenced first, and then the HIV related illness, such as Kaposi sarcoma. Then if it's unrelated, such as a trauma, and that's one they would use trauma. Trauma is always unrelated to the HIV. You would code the trauma first, and then because the patient has HIV, you would pick that HIV up in addition to that. Are they asymptomatic, meaning they've never been treated or diagnosed with HIV? So once they receive B20 as a diagnosis, you can never assign that Z21. Screening for HIV. They're just simply coming in to be screened. Did they receive counseling at the same time? Make sure you read the coding scenarios to see if they were here for counseling. If they came in for screening and they also received counseling, you would code both the Z11.4 and Z71.7. And then other coding guidelines that we have in there are sepsis. So with sepsis, severe sepsis, septic shock, make sure that you pay attention if you get a question on one of those, the coding sequencing. If we have severe sepsis, and did you have shock? Was it with or without shock? So you would have two codes in that particular case. Whereas if you just have sepsis, you would have one code. That A41.9 is that default unknown organism for the sepsis. Same thing with the MRSA, the MESA, and the Zika virus. All right, neoplasms. With the neoplasms, this is the one we're going to use the neoplasm table. And you're going to start in one of two places. You're either going to start in the index for like adenocarcinoma, leukemia, or if it tells you it's a carcinoma or a benign neoplasm, you're going to start in the table. So the neoplasm, you could be asked a specific question on what is a neoplasm. So it's a new or abnormal growth on the body, such as discolored mole or lump under the skin. So that's just telling us growth. It's not telling us is it cancerous or non-cancerous. It's just telling us it's an abnormal growth. There are 6 columns in your neoplasm table. So you have primary, secondary, cancer in situ, benign, uncertain, behavior. So the primary is where the neoplasm started. So you may have the breast. Secondary is where it metastasis, when it metastasizes. So metastatic breast cancer would be saying that primary breast cancer has spread to another area, whereas breast cancer metastasized to, it's telling us that the metastasis again is the second listed, so the other area. So it metastasized from the breast to the lung. So breast cancer is our primary, lung would be our secondary. Cancer in situ is the cancers are contained that line the internal organs, but they haven't spread. So you can have cancer in situ of the pancreas, cancer in situ of the breast, so it's encapsulated. Benign is non-cancerous, and uncertain, we rarely use that unless it's specifically identified as certain by the pathologist. The best rule of thumb is we want to code after we get our path report. However, if it's an emergency department, you're not always going to have that. So you may code just simply a mass or a lesion. But we want to make, for correct coding purposes, to support billing, we want to make sure that we don't code until after the path is received. So how do you find it? Again, you're either going to start in the table in the alphabetic index or in the table of neoplasms. So if you specifically know it's cancer in situ, carcinoma in situ, it's a benign neoplasm, it's a carcinoma of a certain area, we can start in the neoplasm table. But if it's saying like leukemia, adenocarcinoma, we need to go and reference an alphabetic index to get the specifics. Okay. Other guidelines that we're going to use is you want to pay attention to why the patient came in and what is the treatment directed at, especially when it comes to neoplasm. Neoplasm normally is always coded primary or first, and then the other secondary sites, secondary treatments such as dehydration or anemia are coded secondary. However, and we do have chemotherapy, we have radiation therapy. If that's the reason for visit, that's what's going to be sequenced first. Again, if you have a guideline specific question, you need to look it up to verify, don't just guess. Okay, chapter, that should be 3, it says 2, so I apologize. Diseases of the blood, D50 through D89. There's no specific guidelines here. Chapter 4, endocrine, nutritional, and metabolic diseases, E00 through E89. This is where diabetes falls. So we want to make sure that you're looking for the documentation of the type of diabetes. Type 1 are insulin dependent. It's not age based. So just because they say they have juvenile diabetes doesn't mean that it's going to be coded as type 1. It specifically has to say insulin dependent, INDDM, insulin dependent diabetes. So that's type 1. NIDDM is non-insulin dependent diabetes, and that's type 2. If the doctor does not specify type 1 or type 2, type 2 is the default that we utilize. We also want to know, are they on insulin or oral hypoglycemic medications? We want to make sure that we pick up those health status codes, those long-term drug use codes. If they use a combination of insulin and hypoglycemic medications, we're going to make sure that we assign Z79.4 only for those. And then other guidelines that you're going to look specifically at is complications of insulin pumps with pregnancy, diabetes, secondary diabetes. So you want to make sure that you start with the appropriate type. Pregnancy complications are going to be listed under pregnancy complications. Chapter 5 is mental and behavioral disorders. This includes dependence on alcohol, drugs, and narcotics. We've got our depression codes here for mild, moderate, severe, full remission, and recurrent. The other thing that you want to be very aware of, especially with drug coding, is we're looking at hierarchy here. So did they simply use drugs? Did they abuse drugs and use drugs? If use and abuse are both listed, you're going to code to abuse. If use, abuse, and dependence are all documented within the chart, you're only going to code to dependence. So you code to the highest and you only code 1. And then the final 2 chapters that we have here is diseases of nervous system, and chapters 7, which is diseases of the eye. Under the diseases of the nervous system, we focus on pain and migraines here. you're looking at acute, chronic, post-op, or neoplasm-related pain, just pay close attention in your documentation on your example, your coding scenario. What are they saying? So these are pain not elsewhere classified, can be identified as the acute. So we can add those G codes along with the other condition. Then migraines. Migraines, G43. We want the documentation. You're going to look for the documentation. Is it with aura? Are you seeing like a halo? Without aura, is it intractable or non-intractable? And those are the specific verbiage that you're going to see within your coding scenarios. It's not something that you're going to have to identify based on the documentation. It's going to simply state it. The thing to understand with the coding, the diagnosis, is that they are very simple coding statements, diagnostic statements that you're coding for your I-10. And then finally, we have our glaucoma for Chapter 7. What you're looking at here is how to code for bilateral glaucoma with the same stage or different stages. So you want to pay attention to if they have glaucoma, is it the same stage in both eyes? Do they only have it in one eye? Is it different? So you want to pay attention to that. Stages of glaucoma will be required. So you need to know the laterality to determine coding of the correct eye. Okay, so again, with the first 1 through 7 chapter specific guidelines and the introduction, you just want to simply make sure that when you're answering these questions, you go back, you do pay close attention to what the study guide says. If there's any kind of confusion as far as verbiage goes from study guide to your ICD-10, use your study guide. Your study guide, that's where they take most of their questions. So although some of the wording can be a little strange, if it reads directly like it reads in your study guide, that is the answer. You do have coding questions, some scenarios. You have the answers at the end of the book. Those are going to be some of the ones that end up on your test. I'm just going to tell you that. So if you're practicing and you're doing all that, you can go through those and utilize those as answering your questions.